Welcome, everybody, to the CHPR seminar series. My name is Jeffrey Hotch. I am the Associate Director for the Center for Healthcare Policy and Research. You can see as well on camera Dr. Lyle. She is the Director of the Center. And today it's our pleasure to welcome Dr. Katie Conlon. She is going to be talking to us today about climate change and human health. Dr. Conlon is an Associate Professor, jointly appointed in the UC Davis School of Medicine, Department of Public Health Sciences, and the School of Veterinary Medicine, Department of Medical Medicine and Epidemiology. Her research focuses on characterizing how climate change influences human, animal, and environmental health, incorporates traditional environmental epidemiological study design, spatiotemporal exposure assessment, weather and climate modeling, land use modeling, and mixed methods for social and behavioral epidemiology. She works with state and local health practitioners to systematically characterize and implement climate change and public health actions in support of building an evidence base for climate change and health interventions. She was an author on the U.S. Global Change Research Program's fourth National Climate Assessment and the Climate and Health Assessment. Prior to joining UC Davis, Dr. Conlon was an epidemiologist at the U.S. Centers for Disease Control and Prevention Climate and Health Program. He is the principal investigator of the R01 grant called Extreme Weather-Related Events and Environmental Exposures in the Risk for Alzheimer's Disease and Related Dementias, funded by the NIH. Dr. Conlon is a big fan of nature, crosswords, and hot beverages. I'm so excited that she's agreed today to talk to us about her research. Her talk is called Climate Change and Human Health, Impacts and Solutions for Vulnerable Communities. Thank you, Dr. Conlon.
Thank you so much, Dr. Hodge, for a lovely introduction. I'm really happy to be here. I try to cover a lot in this talk, so if it feels like some of what I am talking about is repetitive to you, I'm sorry, just want to level set for everybody who's joining. And if there are questions, I'm more than happy to answer them throughout. So don't be shy. Please raise your hand or put it in the chat and we'll keep an eye out for it. So just because it's important to disclose anything, I don't have any potential disclosure or conflicts of interest. And the research that I'm presenting here are funded by three main agencies, NIA, EPA, and CDPH. And so our learning objectives today, we're going to be talking about the science of global climate change and identifying some of the key mechanisms through which temperature and precipitation somewhat, I don't talk about precip as much, but impact human health. And we're going to talk about the relationships that drive the climate-driven hazards and vulnerability that we see amongst different human populations. And I do want to talk a bit about some of the opportunities that we've seen related to adaptation or mitigation, which are solutions for addressing the global climate crisis. So normally I ask who here is familiar with the science of climate change. And since I didn't put together a poll, I'd just be curious if for those in the chat, just tell me, are you very aware of climate change science, sort of aware, neutral, not aware, or very much not aware of the science of climate change? Generally, when I give this talk, there's a good mix. So depending on the audience, but in more recent years, surprisingly, I've been finding that people are very much in the sort of aware category, which I'm seeing folks respond to. So I'll do my best to address some of the gaps that maybe you have, and we can talk about details if they come up. So this figure, I think, is very helpful to demonstrate the agreement amongst climate scientists on the changing climate that we're seeing globally. So this comes from the World Meteorological Association, and what it is showing is from the beginning of when we started to take temperature records and what we can extrapolate records from our ice cores in 1850 all the way to current day, 2024 would be the last, what the global mean temperatures are every year. And essentially this is looking at the departure from the average. And we see 6 different models. So these models are using different small tweaks here and there to model better over land surface different land surfaces like mountains or plains. Um, but the key point here is that you see in more recent years substantial agreement that we are seeing an increase in global temperature, and all of our models are for the most part capturing that. And we can take a look at our data that gives us this information. So this is a map that's showing a progression of changing global surface temperature anomalies. So normal temperatures are shown in white, higher than normal temperatures are in red, lower than normal temperatures are in blue. And these normal temperatures are calculated over a 30-year baseline period. And here we're seeing map averages over a running 24-month period. This final frame that we're going to see represents the global temperature anomalies in 2024. And I'll just show this again because I think it's pretty impactful, where we start to see, and of course it likes to stop around 1890. Here we go. 1893. Okay. Oh, maybe it just doesn't want to work. Well, what I'm trying to demonstrate here is that we see these changes happening more rapidly in more recent years. And where we're seeing these increases temperatures, they start at the poles and then they start to show more along the equator, but then very quickly around 1970s, we start to see our land masses experience higher temperatures. In the US, recent summers have been about 1.5 degrees Fahrenheit warmer than 50 years ago. And we can see that as global climate change is going to progress, the distribution of observed temperature shifts higher. And as those distributions shift, higher temperature extremes become more likely. And so here we see another graph that's demonstrating these anomalies. So departures from the normal, or departures, excuse me, from the average. And the average period is from 1850 to 1900. And the last 10 years have included all 10 of the warmest years ever observed in instrumental record. 2024, last year, was the warmest year on Earth since 1850, and that exceeded 2023, the 2023's record that was set with a very clear and definitive margin. Our global temperatures in 2024 were 1.3 degrees Fahrenheit or Celsius, which is about 2.3 degrees Fahrenheit above the 20th century baseline average. And this new record came after 15 consecutive months, so June 2023 all the way through August 2024, of monthly temperature records. So it is getting hotter and it's continuing to get hotter. And we might be thinking about, what does this trajectory look like? And this figure I think is really wonderful. It comes from the Intergovernmental Panel on Climate Change, which is a global consortium of climate scientists that assess the state of the climate globally. And they do that about every 4 years. And here we see a figure that's showing across 3 different generations what somebody born in 1950 versus 1980 versus 2020 experiences in terms of temperature over their lifetime. And I'll just point out that when we talk about climate change, we are talking about things in terms of scenarios, because that's how we as scientists use our planning tools. We have to think about how might global temperatures change as a result of our changing greenhouse gas emissions. And so we do that through these scenarios, which you see in these horizontal bars. So very low, low, intermediate, high, and very high. The very low scenario assumes that we would stop all greenhouse gas emissions today. We would still, you can see on that bottom row, we still would see some warming because it's what we call baked into the system. But then as you increase those scenarios where we see larger contributions of greenhouse gases, those temperature impacts are pretty high. And in fact, we are currently on the very high trajectory. That is the scenario that we see at the top. And we can see that if we are looking out to the end of century, we would expect to see global temperature change above 3.5 to 4 degrees Celsius. So if you have a loved one who was born around 2020, you can expect that if they were to live to their 70 years old, they would be experiencing incredibly high temperatures. So if you remember, and I see you, Dr. Hodge. I remember, if you remember, last year our average was 1.3 degrees Celsius. So yes, Dr. Hodge.
Oh, thank you, Dr. Conlon. There's a question in the chat from Irina.
Ah,
Irina, are you okay to go off mute and ask your question?
Sure. Yeah, I was just wondering kind of the rationale of comparing from 1880, and if there any reason in looking at kind of evolution of the temperature changes over the previous centuries compared to where we at more recently.
yeah. So you're talking about in general, we like look at this period from 1850 to 1900, this average period, because that is around the time when greenhouse gas emissions were essentially created by humans. So this is the Industrial Revolution. This is when we started to use coal, and that is a substantial source of greenhouse gas emissions. So it is one of the ways that we are able to best communicate the human contribution of climate change.
I
Um,
see.
yeah, but
Okay.
we do, as you, I think in this figure, um, I believe I was trying to look at my notes. In one of these figures, they are, or maybe it's a later figure that I have. We do look at more recent years, and part of the reason for that is because if we want to look at what we call adaptation, so how humans are adapting to climate change, we need to have a sense of, like within my lifetime, how have I experienced climate change, and how has that impacted my health?
Yeah, yeah, thank you for that. I was
Yeah.
just thinking, kind of historically, we know that there have been significant changes in the planet Earth, with, I don't know, oceans drying out, reappearing and so forth. And I understand their intention is the human element in this. I was just wondering if there is a interest in compare human versus non-human element in terms of the evolutional changes that happen over time, regardless of human input.
Yeah,
Um,
we have, I didn't include it in this talk, but in that same report that I just showed, the IPCC, and I'd be happy to share it with you, they do a lot of modeling studies to illustrate, if humans were not contributing to climate change, what would you expect global temperatures to be today or in the last
mhm.
30 years? And in those models, even with like the highest emissions of CO2 or other greenhouse gases that we see driving climate change, coming from like what we call natural sources, even with those being at the highest feasible emissions, they don't even touch the contribution that humans have. But there's a really nice figure that shows it. I mean, the departure is staggering.
Mhm, mhm. Okay, great.
Yeah,
Thank
it's
you.
great. Yeah, great questions.
Thank you.
So the point of me talking about all of the science, climate science behind that is because we really, I feel, in the field of public health, have a responsibility to be thinking about future generations. And it is very clear, and it is agreed upon by almost all climate scientists and environmental health scientists working in climate change, that without any uh, accelerated intervention, that this problem is going to be the defining problem for future generations. And when I think about climate, most of my work has really focused on populations that are more at risk to some of these climate driven exposures. And we know that there are around 3.5 billion people that currently live in what we call hotspots of vulnerability to climate change. So these are populations that live where there are lots of floods related to high precip events, extreme heat events, coastal typhoons, and tropical cyclones, drought that can lead to malnutrition, And so this is important because we can think about how to prioritize our activities when thinking about who is most at risk. And so when we talk about vulnerable populations, we can also talk about them in terms of populations at risk. And these really range from those who have biological conditions that might make them more more susceptible to struggling during extreme heat, for instance. There might be demographic characteristics. Older folks, younger kids have a really hard time, for instance, when there's poor or when it's really high temperatures. Various geographical and socioeconomic conditions also can make people more at risk to these climate-driven exposures. And I do see that there is a question. I just wanted to state that climate change has these unequal impacts, and we can think about through all of the already existing social determinants of health, climate change magnifies those threats. And so it is called what we refer to as a threat multiplier. Okay, so I have to read, Gloria, to your question. I'm going to be a little slow. Do we have an understanding around what types of emissions and how much emission control we would need to reach a point of stability? Yeah, if we go back to these scenarios, so I want to just bring your attention again to this very low scenario. So our emissions, for the most part, are CO2, so carbon dioxide. That's the one that you hear most about. That comes from transportation. It comes from agriculture. It comes from health science, or actually hospitals. Hospitals in the US account for 8% of greenhouse gas emissions. So there's a real substantial opportunity to limit our greenhouse gas emissions that way. But to reach a point of stability, I think if you're asking, can we go back to what it was? If we were on this lower, very low trajectory, which would require us to stop this very moment emitting any kind of greenhouse gases, we would still see some increases in temperature because, as I said, there's already baked in impacts of heat in our system. CO2 and other greenhouse gases, when emitted, they can stay in the atmosphere for a very long time. So when they're emitted, they are involved in a process that helps trap heat in our atmosphere. The more that we have in our atmosphere, the more likely we're going to be able to hold on to that heat. And for certain molecules of greenhouse gases, they hold in a lot more heat, but leave very early, like methane, or very quickly. But CO2 holds in a good amount of heat and it stays for a really long time, which is why we see it baked in. And I see your question about, since industries are responsible for emissions, how much have the models been able to account for and adjust for this change? The emission, or the models, they use different scenarios that assume like a low emissions industry. So as we, let's say, moved more towards solar, these emission scenarios account for that. I hope I'm answering your question. Okay. Okay, so back to the climate gap. So there are a few different ways through which we experience climate-driven exposures. And so we can see that in this figure, which I think is really nice, it shows that we have these different climate-related hazards. We're talking about extreme weather events, heat, sea level rise, air quality, changes in distribution of vectors, water scarcity, changes in our food production. We see that people's exposures can differ based on a variety of factors on the right, and on the left, those vulnerability characterizations that we want to think about. And so those can tinker with, how much or how little somebody is exposed or vulnerable. But we know through epidemiologic studies that there are a variety of health outcomes ranging from injury and morbidity to waterborne, vector-borne diseases like Zika, like dengue, all the way to mental and psychosocial health outcomes. And so I'm going to focus mostly on air quality, heat, and some mental health outcomes that we've looked at. And so here, the mechanism of action is that we see, and I will be focusing on wildfire smoke, that when were wildfires, we have an increase in potential for cardiovascular disease, respiratory disease, and mental health stress. And why is that? So this is a figure that comes from the EPA. And I think it's really nice because it shows an overview of the known and suspected pathways through which wildfire smoke causes various health outcomes. And so we can see that essentially this exposure can end up causing tissue remodeling, cytotoxicity, and altered respiratory response. This picture on the bottom right shows the relationship of what we call the particulate matters that we look at. So fine particulate matter is this red ball, this sphere, PM 2.5, that comes from the combustion particles that we get from traffic-related air pollution, things being essentially being burned. And you can see that they are very small. They're smaller than the size of the diameter of a piece of hair. I also am working, in addition to looking at PM 2.5, I look at some PM 0.1, or also known as ultrafine particulates, and those are about 25 times smaller in diameter than PM 2.5. So what are the health impacts? We know that air quality ranges in its health impacts. It can exacerbate asthma, it can cause acute bronchitis, it can have impacts on cardiovascular health, including cardiac arrest. We know that there are relationships with adverse birth outcomes and mental health outcomes like PTSD and anxiety. And I'll talk a bit about my project that looks at outcomes related to dementia. And so this figure, or this picture, actually happened in 2017, and I think down in Kern County. And it's a picture of our outdoor workers, our farm workers, who are picking in the midst of essentially a smoke plume. And so we know that there are these vulnerable populations that get exposed for different reasons. And these are really where a lot of my research has been focusing. And as I said, I focus a lot on wildfires. So we know that the season of wildfire, we don't even call it seasons anymore, we call them wildfire years. Those have increased substantially, and they're about 5 times as longer as they used to be. So this is a figure from a paper that we published in AJPH. We were looking at the Social Vulnerability Index, which is an index that the CDC publishes. I actually don't know if it's up anymore. But essentially what it is trying to do is take a lot of census data and assess who would we identify as socially vulnerable. So these are populations that maybe don't speak or have English as a second language. Maybe they are multi-generational homes. And we overlaid we did an overlay analysis where we looked at social vulnerability and wildfire smoke. And we looked at wildfire smoke categorized as light smoke, medium smoke, and heavy smoke. And you can see that heavy smoke is very much covering over this time frame, this 11-year time frame, or 22-year time frame, 12-year time frame. I do know math. Much of the United States in the bottom right. And when we look at, and that's where we see a significant increase. The red is the significant increase. And when we overlay it with that social vulnerability index, so on this grid is showing that as you increase your vulnerability on the bottom right in that green, and then as you increase your heavy smoke exposure into that top pink, purple, that's where that intersection occurs. And we found that there is actually a 350% increase in the average annual number of heavy smoke days in those vulnerability or highest vulnerability census tract groups. So this is very interesting. And as I go through the rest of my slides, you'll start to see a pattern that is no pattern. It's very challenging to understand who is most at risk to wildfire smoke because there are a lot of different components that contribute to risk. But if you were to just look at social vulnerability, here we see a lot of our rural populations are exposed to high smoke days and high vulnerability. One project that we are very excited about, this is the PI on this is Dr. Rebecca Schmidt, who's also in the Department of Public Health Sciences. This is/was funded by the EPA. And what we were looking at here is wildfire smoke exposure and pregnancy and developmental outcomes. And so we are using a large database of births in California, over 11 million births. And we wanted to see how exposure to wildfire smoke relates to these different pregnancy outcomes and neurodevelopmental outcomes. We know that pregnant populations are at high risk for having preterm birth and low birth weights, as it relates to both wildfire smoke and poor air quality. And we also know that there are birth outcomes that are of concern related to poor air quality. And so we specifically were looking at birth weight, preterm birth, autism, developmental delay, and cerebral palsy. And what's cool about this study is that we're using a chemical transport model, which I also am using in another study, which allows us to actually track specifically wildfire smoke exposure. And that is something that's not commonly done for a lot of these analyses that are looking at air quality and wildfires. But so from this preliminary analysis, we found that amongst those individuals who had repeated high exposure episodes, and so here it's above 35 micrograms per meter cubed, and that is, for anyone who is familiar with the AQI, that is the unhealthy for sensitive group category. So when we had repeated high exposures, we saw an increased risk of autism spectrum disorder. And what's interesting about this is that those who were exposed in that top percentile, they had a 17% increased risk compared to those within the median percentile. And even further, for every additional episode beyond what we called a 3-day washout period, we saw an increased risk of 10%. Then if we gave individuals a 7-day washout period, we saw an increase of 12%. So we're starting to get a sense of what are the cumulative exposures that individuals are experiencing and their outcomes on birth outcome. And we can see here that this is evidence for a need for more detailed analyses of birth outcomes. And so because it's a natural transition, let's go to the other end of the other spectrum of our life course and think about dementia and Alzheimer's disease. So this project is very broad in that we're looking at as many environmental exposures as we can. Specifically, we're looking at weather-related extremes, so extreme temperatures, precipitation, air quality, both that fine particulate matter and that ultrafine particulate matter, and then toxic environmental contaminants like lead, arsenic, cadmium. And we want to know the relationship to cognitive function, Alzheimer's disease, and various imaging markers that we have in a really diverse population. And so this is just a figure to kind of illustrate this project. And ultimately, what we're really hoping is to be able to demonstrate that over the life course, we can look at these environmental exposures in a very diverse population in California and get a sense of how those exposures can influence brain health in the long run. And so we have 3 cohorts. You might be familiar with these, but in case you're not, these are cohorts that come out of Kaiser, Northern California. These are cohorts that are run by Dr. Rachel Whitmer. The Candle, Star, and Life After 90 cohorts are specifically designed to represent diverse populations. So a lot of the Alzheimer's disease and related dementias research have focused on white populations, and these cohorts are specifically looking at non-white populations. And then interestingly, for the Life After 90, individuals over the age of 90. And what's really cool about these cohorts is that we have hit historical residential history. So we can go back to when they were the participants were very, very young and identify where they were living at that time. And all of their neurocognitive assessments are harmonized. So we have an opportunity to potentially pool these cohorts and look at them as one, which gives us a lot more statistical power, which is something we're always looking for. This is just a table to show the diversity of the two cohorts that we've started to analyze, which are Candle and Star. I'll just point out that Candle participants were diverse by race and ethnicity, and that's in part reflective of the sampling strategy. The Star cohort is identified mostly as Black, and that was also by design. But we have substantial diversity in education level, and where people and marriage status and annual income. So here I'll just focus on air quality and cognition. So we're asking the question, what is the relationship between long-term PM2.5, which is what we call fine particulate matter, and ultrafine PM0.1 exposures and cognitive function in both of those cohorts? I will just say that there is a very substantive literature that demonstrates that air pollution is very dangerous to brain health, with most of that work being done in using PM2.5 data. And a lot of the brain health outcomes that have been assessed have been general cognition. And so what's cool here is that we're actually looking at 3 different types of cognitive function. Executive function, which is kind of like your working memory, episodic memory, which is how we would refer to like specific experiences, and semantic memory, which is a long-term memory. And additionally, when we just backtracking to the air quality data, most of the studies that have looked at PM2.5 have generally looked at exposure periods over 1 to 3 years, and we're able to actually look at long term. So we have estimates at the 5, 10, and 17-year average. And so we ran models that are looking at these relationships to try to get a sense of what that long-term air quality does to baseline cognition. And so this figure is information packed. So I'll try to walk you through it. We have both of our cohorts, the Candle cohort, which, as you remember, is very diverse across a variety of race ethnicity categories, is represented by the solid marks. So if you're looking at the executive function box in the top 2 lines, the solid blue, the solid red, those are for Candle. Those with the hollow diamond, the hollow circle, those are for Star. And so here we can see that in our Star cohort, so that group that has the hollow, long-term particulate or fine particulate exposure was associated with lower semantic memory in both our fully adjusted models, and the strongest association was in that longest time frame at 17 years. The Candle cohort, on the other hand, long-term ultrafine or a long-term fine particulate matter exposure was associated with lower semantic memory in our minimally adjusted models, but not in those fully adjusted models. So what we're learning here is that there might be something going on with these long-term exposures and the impact that it has on that longer-term memory. And because I work with a really cool, diverse team of scientists, I just wanted to illustrate this. I mean, this data is really special. It actually, I think, only exists at UC Davis. And the ultrafine air quality data is given to us by Dr. Mike Kleeman here at Davis. And this is just illustrating the fine resolution of what he can provide. So he can provide this data at a 1 kilometer resolution, which might not mean a lot. The previous, a lot of our other data is available at 4 kilometers. So this is really cool. This allows us to really capture how spatial distributions of exposure are vary across our participant population or cohort population. And what's also really cool about this data is that he is able to link certain concentrations to certain sources of pollution. So most simply put, we are able to model particulate matter, the very fine particulate matter, which again, remember, is 25 times smaller than the fine particulate matter. So it gets deeper into the lungs. We are able to look at that pollution that's caused by wildfires, and wildfires that happen in what we call the WUI, the wildland urban interface. So what we just saw in January in LA, those would be called WUI fires. And those fires are not just a wildland fire, right? Because they, in addition to burning biomass or trees, vegetation, they're burning people's homes, they're burning people's refrigerators, their cars, all sorts of things. So that changes what is in the particulate matter that somebody might inhale. So I'm not just showing that because I'm a nerd, I'm showing that because it's important, I think, to demonstrate what's happening here. So what we really wanted to look at was using that fine particulate matter and looking at our baseline cognition. And so we looked at what is called total PM. So just saying, okay, of all of the different types of ultrafine data or ultrafine exposures, what is the relationship with cognitive function? And we wanted to look at it by race ethnicity. So we see the same setup where we have our 5-year, 10-year, and 17-year exposure periods, and we have it by the total population. So this is combined star and candle, those two cohorts, and then by race ethnicity. And we found that there were no effects in this main model, and there were no effects by this total PM. But when we looked at the WUI fire, the WUI fire, so those are those fires that happen in urban areas, so you're burning more than just the biomass, we find a pretty strong relationship of effect modification by race and ethnicity within this 5-year period across all of the cognitive domains. And very interestingly, amongst our non-Latino white population, which is this pinkish red color, that we saw an increase in that 5-year average. An increase in this 5-year average was associated with a lower semantic, executive, and verbal episodic memory measure. So we know that there might be some differences in exposure and outcomes based on where people are living. So we can think about, we're going to be exploring this a little bit more in some of our other analyses, but it was really interesting because if you remember back to the analysis I showed you about social vulnerability across the US, those with highest vulnerability were those individuals who were experiencing the highest levels of those of heavy smoke. Okay. And because nothing is simple, I just want to double check the time. I want to show some work that a former student of mine we're publishing it like this month. It's actually been accepted as in press. Some of her work on compound hazards. And so when we're thinking about compound hazards, and I should note she was a graduate of the PhD program. So if anyone's thinking about that, we can do some really cool stuff. And with compound hazards, the reality is that we are not exposed to just extreme heat. We are not exposed to just wildfire smoke. We're exposed to a lot of these things at the same time. And so we looked at what are the exposures that Californians are experiencing to both heat and to both wildfire smoke at the same time. And so this image is showing in 2020 across what we call ZICTAs. So these are zip code tabulation areas. This is a boundary unit that essentially is capturing all the zip codes. And we see on the left where we have our high heat exposure days. In the middle are the distribution of wildfire smoke exposure days, and then the two combined. And it's pretty clear that, unsurprisingly, right, in the Sacramento region, we have very high heat and we have very high smoke And this is in 2020. I don't know if anybody remembers, but 2020 was a pretty hot and smoky year. And when we wanted to get a sense of like, what does that look like in a recurring setting, we saw on the left that the distribution looks very similar for these compound hazards across the state from 2011 to 2020. So it's like pretty consistent. What we saw in 2020 kind of represents what we see across a 10-year period. But we wanted to know who is frequently getting these compound hazards. And that's what this figure on the right is showing us. Which areas are frequently getting really high, really smoky days. And that for us is us. That is Northern California, that is Sacramento, Yolo, and then parts of the Central Valley, unsurprisingly. And when Caitlin looked at this, she wanted to see just descriptively which communities were the ones that were seeing those highest compound hazard exposures. She saw those who had lower average incomes or household incomes. She saw these were highest amongst minority groups, but and lower amongst white non-Hispanic groups. There wasn't any association by education, but then she did see that there were highest compound hazard exposures amongst those who live in urban areas compared to rural areas. And this is really helpful when you think about how this research can be used for public health action. Because when you all are going to be working in public health or at the county health department, you're going to be asked to distill some of these complex analyses to make decisions about how you can protect health. And so we can think about targeted interventions by using this data. And I also wanted to show some of her work that was looking at the joint effects of extreme heat and wildfire smoke. So because they don't operate independently, we wanted to look to see how they relate to each other. Do they amplify each other's effects? And we found that they do. So this study specifically looked at HCI data, which is morbidity data in California. And Caitlin used a case crossover analysis and did a conditional logistic regression to estimate these effects at both the multiplicative and additive scales for any of those who are interested in the epi side. And we looked at 16 different combinations of exposure lag. So I didn't talk about it, but there is a robust literature that shows that when exposed to extreme heat, there is a lag period of about 1 to 2 days where people get really, really sick. And so we wanted to consider that in this analysis. And so we have those 16 combinations of exposure lags and the outcome of interest on the bottom. So just to orient you, lag 0, 1, for instance, here is saying that on a day where there is extreme heat, that's what lag 0 is. And when there was a wildfire smoke day the day before. So day of is 0, day 2 is 2 days prior. And so what was very interesting was that these joint effects differed across these main outcomes of interest. So respiratory cause, renal cause, cerebrovascular cause. And I'll just point out that the largest additive effect happened with our respiratory combination at lag 0.3. So a day that was very hot, if you were also exposed 3 days prior, we saw hospital admissions. 8% of the hospital admissions for respiratory disease were due to this joint effect. So this tells us that there is an effect of having both extreme heat and wildfire smoke happening in a certain time frame, and that is really challenging public health messaging. And we found that because this was in review for a very long period of time. How do you talk about this? And we did see, and I'm not going to present it here, but we did see some stronger effects when we looked at subgroup analyses. So amongst Black individuals, we saw a 19% association, or 19% of respiratory admissions were associated with this combined effect amongst Black individuals. And I'll just quickly talk about two other projects that are near and dear to my heart. So I've done a lot of work thinking about extreme weather, so not just extreme heat and not just wildfires, but the other experiences that we see with climate change related to storms and droughts, and the outcomes that are very much associated with extreme weather are related to mental health. And you all might have felt this at some point during my talk, but this term eco-anxiety was coined by the American Psychological Association, and it is a chronic fear of environmental doom. And the term solastalgia has also gotten a lot of attention because it is this experience of feeling a sense of loss for what once was. And I bring this up because there is a very growing literature and interest in the mental health impacts of climate change. And it ranges from depression and anxiety and PTSD all the way to gender-based violence and aggression. So it's really important to talk about what these potential impacts might be, and how all different populations are experiencing them. And we saw this very much so in a needs assessment that we did, that was recently published. So we had a survey that was given to survivors of the 2017 Northern California fires that happened in the Napa-Sonoma area. And so we asked two open-ended questions. What was your household's greatest needs 1 week after the fire? And what was your household's greatest needs currently? So we gave the survey about 4 to 6 months after the event happened. And we refer to those as the time of survey needs. And what we saw were 4 major themes. Unsurprisingly, the most commonly reported theme was physical needs. And these were things like the basic needs. I need a toothbrush. I need toothpaste. I need to take a shower. I need a place to live. And we also looked at how those needs changed over time. And interestingly, you can see within that physical needs category, we have a persistent category. And we saw a switch. So at the time of the fire, people weren't thinking about financing and weren't thinking about rebuilding their home. But unsurprisingly, that was something that they were thinking certainly about at the time of survey. And we also saw 3 other different categories of needs, ranging from air needs, so I need clean air, to health and information needs. And amongst those health needs, mental health needs were most reported at all the time points across all of the health themes. So this indicates how important it is to think about wildfire survivors' mental health. And we're using this as a jumping off point to do additional research to hopefully explore that. And lastly, I'll end on a bit of a positive note. So part of this talk was intended to be about solutions, because the reality is most of the science right now is about impacts. What are the impacts? What are the impacts? But if you're like me, I'm like, what are we going to do to protect people? Okay. And this is a really cool project that I'm working with CDPH on. It's a weatherization intervention in Tulare County. So we're working with the state public health office, Kauai Health, which is a health provider in Tulare, and a weatherization group. And we're doing an intervention on weatherization where we go and we do an assessment of an individual's home, and we see, are you eligible for getting new windows or having insulation, and all these different weatherization techniques that can potentially reduce indoor air pollution and also make indoor temperatures more comfortable. So if you've ever been in Tulare county in the summer, you might understand why those are our main goals. And my role in this is to do an evaluation. So we really want to understand how likely is it that this type of program is actually adopted, and is it feasible beyond just a pilot? And do we see effects on housing quality, on energy use, on costs? And can we look at various health outcomes? And so this project is using a Promotoras model, which is really great. We have our community health workers that go out and they engage with our potential participants in the intervention. They enroll, they do, they are now trained in what weatherization is, which was a really fun experience. And our participants are CHPR patients. We think we're going to be expanding it from their enhanced care management program, which focuses on low-income farm workers and monolingual Spanish speakers, but also to include Medi-Cal population. What's really cool about this is that we are going to have renters, which means that we have to get agreement from the homeowner, which might be a landlord. But the idea is that weatherization doesn't have to, might not be a low barrier for any population if it's something that you can scaffold appropriately. So we're going to be evaluating that and hopefully have some preliminary results in a few months, actually. And so I just want to take a minute to acknowledge the diversity of the team that I work with. In climate and health, you oftentimes wear a lot of different hats. I work with people who are climate scientists. I work with people who are engineers. They provide me a lot of the models that I've discussed. And then I work as an epidemiologist with my epidemiology colleagues, but I also work very closely with public health practitioners and evaluators. So with that, I can take any additional questions. I know I kind of went through that fairly quickly.
That
There's a
was
lot.
great, Dr. Conlon. Very, very interesting. Well presented. Let's start with some of the questions in the chat. Gloria, I'm going to call on you to read out your question if you feel comfortable, and then we'll go hear some more about HCI data if William is okay to give a shout out to HCI. Glorietta, are you all right to ask your question to Dr. Conlon?
Yeah, sure. Thank you. Thank you, Dr. Conlon. My question was around those timeframes that you had shown for the exposure to defined particulate matter, so 5, 10, and 17 years. And my question was around the individuals in that timeframe. Did these individuals state that they hadn't moved, so they were consistently exposed to those levels at the particular location for that stretch of time?
Yeah, so we do have so we have data on these individuals' residential histories. So we are assuming that they stay, we limited the analysis so that if they were at their location for 17 years, then they get that 17-year average exposure for that location. But we do account for moving because we have these particular estimates across time.
Thank you.
Super. So we've got a bit of time for questions for Dr. Conlon. You can actually raise your hand. You can virtually raise your hand. You can type something into the chat if you would like. Dr. Conlon, for the students who are watching, and maybe even for the faculty who want to potentially work with you, how does, do you work with mere mortals, or like how do people, how can people find out a bit more about opportunities to collaborate with you?
Yeah, I mean, the classic cold call, just give me an email. I have quite a few projects that are ongoing. We, like everybody, are also in a bit of a state of flux. So some of this might change over time. As I mentioned, the analysis that we're doing with pregnant populations and developmental outcomes has been terminated by the EPA as of 10 days ago. But we are still, we're going to take a lot of the work that we've done and continue it. And we do need support for that, right? Like, unfortunately, it might be pro bono, but, we are large research teams that we, have a good bit of work that we need help on. So yeah, if there's a project that you're interested in, I'll say that the needs assessment paper was taken up, was initially started by a GB, or she was helping me. She was a GBD, so an undergrad student who wanted to do her practicum, and we put that paper together. So there can be light at the end of the tunnel if you're working on a project that feels like you're doing pro bono.
Oh, thank you, Dr. Conlon. I think there's also a question from William. William, did you want to pose your question or comment about HCI data?
Yeah, sure. Thanks, Dr. Hodge. And Dr. Conlon, it's just so cool to hear about all your work that you do. And so great presentation. I am a epi over at HCI, so it is really cool to see our data being used in ways in which when we published it, we didn't quite expect it to be published or used in that way. So yeah, it's great. Thank you so much for using it. And then for all of the other folks out there who may be looking for a new data set or maybe looking wanting to do something else very cool. HCI has a ton of data, and I don't think I see any of my supervisors on here, but sometimes we're not the greatest about getting it out there. So I'm going to put a email to our data and reports folks, and if you email them, they can help get you connected to data sets or I don't know, help you get connected to some of the products we have out there. So thank you for
Yeah. And I
self-promote.
can add to that. The HCI data, I mean, was huge, which is great, right? Like Caitlin ran, as I said, 16 different combinations of exposures. She needed a lot of statistical power. The only way she would have been able to do that is with a data set like HCI. So I'll also add, and you probably know this, Will, but the HCI data was free for her as a student. Me, as an investigator, I would have to pay, but she was able to get that data at no cost for her dissertation research. And yeah, I think it's really helpful data. Again, it is hospitalization data, and it can take a bit of time to get, but we all know how to fill our time these days, right? So it's worth it.
Super.
For any students out there, I am the coordinator who works with students. So
Oh,
if you want to hang out with another former MPHer, that's me.
nice.
Thank you, William. All right, so we've got 2 minutes left. I'd like to give 1 minute to our director, Dr. Lyles, and like to give the last minute to Dr. Conlon for her final thoughts. Dr. Lyles.
Such a great talk, Katie. I just have a question. Have you been thinking about AI or machine learning models, like get the wealth of data that you have or partnerships in that space?
Yes and no, if I'm honest. Uh, and the no is because it feels like a bit of a barrier to entry. It's not something that I've used in the past. That doesn't mean I'm not interested in it. I think that it's very interesting. I've had this is just a side conversation about AI and the contribution that it has to climate change is like something we talk about a lot, like in the proverbial water cooler. But I'm not opposed to it if it is going to produce better research, right? I mean, that's what we need. And in some case, I mean, we might have to really start exploring that because the data sources are being taken away. And so we rely heavily on monitoring data. We rely heavily on satellite data. If that is not available to us, we need to find something else because we don't want science to stop. So yeah, that's a great point, and I'm glad you brought it up. And if you know somebody, I would love to talk with them.
So maybe those two will be in contact. Katie, we've got about 10 seconds left. What are our final thoughts for today? What do you recommend us thinking about all the wonderful things you've shown us?
Yeah, I mean, I think that climate change can be a really tough topic. It feels, when I give these talks, sometimes it's a little like, oh my gosh, the wet blanket. We have to remember that there are things that we as individuals can do that move beyond just like, I need to watch how much I drive. We have to force our institutions to start talking about climate change beyond the inconveniences of having to solve the problem, because we are all going to be impacted by it. As those who are listening who are thinking about their own research, I was joking with Dr. Hotch earlier that I can almost always connect climate to something. You can probably find a climate connection to your work. It might not be something that you want to act on, but just have that worm in your head, because it's not going to go away and you're probably going to have to think about it at some point in your career.
Super. Thank you so much. We appreciate you sharing all these interesting ideas and the open invitation to follow up with you using the information that's on the screen. Thank you again, Dr. Conlon. It's been wonderful to hear from you today.
Yeah, thanks, y'all. Appreciate it.
Bye for now. Thank you, everyone.